Good morning, everyone, and welcome to my presentation. Today, I would like to highlight to you the link between respiratory health and cerebral palsy. My name is Erika Kolumbán. I'm a conductor-teacher working at András Pető faculty, Semmelweis University, and my research was carried with the guidance of Ibolya Túri, Mark Hernát-Fői, Dániel Veres, and Ádám Zolcsák. As a conductor and teacher, I have the vision to improve the rehabilitation system of children with cerebral palsy, and I have the mission to make advances in the cerebral palsy treatment through evidence-based breathing exercises. So in order to achieve my mission, we set two specific goals. The first one is a meta-analysis to compare and to see the benefits of the supplementary respiratory therapy. And the second one is the plan of the randomized controlled trial. Let me introduce to you the first one. To the background, as you know, cerebral palsy is the most common disability among children, and it affects not just motor development, but also the respiratory health, and unfortunately nowadays is still the leading cause of death among this population. So, and we know that this respiratory health status is closely linked to the self-care activities, social adaptiveness, so actually influences the daily life of our patients. The current consensus statement advises us professionals to perform regular preventive exercises and assessments. If the child is diagnosed with cerebral palsy, receives a conventionally physiotherapy or a neurodevelopmental treatment. However, there are existing supplementary respiratory therapies with a device or manual techniques or breathing exercises in a playful manner. These exercises are cost-effective, easy to perform, and easy to access for all professionals. And our aim was to investigate if we add this different respiratory therapy to the conventional care, we will find improvement on the pulmonary function and respiratory strength. So we formulate the question, and we used the PICO framework, and we compared conventional therapy and conventional therapy versus supplementary respiratory therapy. We searched for measurable changes in the pulmonary function, respiratory muscle strength, quality of life, and we hypothesized that we will find improvement in these outcomes. We conducted a systematic search in 5 major databases, and finally we found 12 eligible articles, and these articles are randomized control trial and allowed us to extract data of mean differences. And here on the first forest plot, you will see the results of one pulmonary function called PEF, the peak expiratory flow. In the articles, they differentiated and they measured in percentage in liter. That's why I present 2 forest plots. And they involved patients with different kind of cerebral palsy, like hemiplegia, diplegia, and tetraplegia. However, on the right side of the plots, you see that the studies who show benefits in the favor of the intervention group, and we find statistically significant results in the studies who measured this pulmonary function in liter, and not statistically significant results in studies measured in percentage. However, we considered both of the results clinically meaningful changes in compare to the intervention before and after, because this level of the change reached the minimal clinical important difference, which is 5%. In case of respiratory muscle strength, which is measured in water centimeter, here you can see that with relatively small sample size and high heterogeneity resulted in statistically not significant result, but however this reached also the increase of 5%, which means for us that these results are clinically important. In regarding the quality of life, unfortunately, we couldn't conduct a meta-analysis, but the literature shows that we will find improvement in social and emotional well-being, acceptance, and which very important is also can reduce the bodily pain and increase the vitality in our patient population. So in conclusion, we can say these various supplementary therapies in patients with CP classified with gross motor function level 1 and 4, so the most vulnerable group 5 was not presented in our data, demonstrated clinically meaningful improvements in pulmonary function and respiratory muscle strength. These improvements suggest the potential for an enhanced quality of life, and we suggest to incorporate these therapies in the standard care. So we included only randomized trials, but unfortunately we have no data related to quality of life. Our manuscript was submitted to the Journal of Clinical Rehabilitation, and today we are planning to send back the author response letter to the journal. Just briefly, our second project, and to the background. Maybe all of you know the Hungarian conductive education system, which was designed by Dr. András Pető in the 50s in Hungary. And his game-changing novel approach already in 50s included breathing exercises in his regime. But unfortunately, we don't have a clear protocol, or no similar research has been done on this matter, and we need a randomized control trial to find evidence-based benefit on our protocol. So we set the clinical question: if we protocolize the conductive breathing exercises, do we find changes in the pulmonary function in our children? So we would like to compare the protocolized conductive breathing exercises versus standard care, and we are searching for measurable changes in the pulmonary function, quality of life, anxiety level, eating and drinking ability, and severity of drawing. So, and we hypothesize that our special breathing exercise will improve the respiratory health of children with cerebral palsy. Firstly, we conducted a very thorough analysis of the manuscript of the heritage left by András Pető, and we analyzed more than 8,000 pages like this. These are case reports and exercise series, and we find more than 1,700 tweets related to different diagnoses, and we identified different breathing techniques which are also used today, and recommendation to the ventilation and how to use these exercises. So we are planning to draft an intervention and to compare, introduce this kind of exercise series. We are searching for the following outcomes, and our plan is to start this trial on the 8th of April this year. So these are, in summary, my two projects. And I would like to finish my presentation with a quote: "For breath is life, and if you breathe well, you will live long on earth." Thank you for your attention.
I would say that this is a kind of note, because I don't want, this is for your study and the previous one too. So at least, Miklós, please blame on us when we say that something is statistically not significant but clinically relevant. The reason for this, because there are strict rules for randomized clinical trials, for in vitro experiments, for preclinical experiments, but it's not absolutely the same for meta-analysis, because what we do is actually we bring together very heterogeneous data. And then, when we put this together, if we could see one of your forest plots showed that actually some of the studies were significant, as it is,
yeah.
And some others were absolutely not.
Mm-hmm.
And then at that time, actually, we judged not only strictly the numbers, but also the overall picture. And if the deviation from the control seemed to be kind of importantly deviating, then we say that this is a critically relevant thing, which doesn't say that is really an absolute truth that is the effect, but that is something most meta-analyses actually show this, that this could be very important, and further studies are needed, just like you said. Mm-hmm. And that came up in the previous slide presentation and in this presentation too. Sorry, we usually don't give this kind of.
But so it's very important that I do not blame anybody, and mostly not the CTM.
Yeah.
So I just try to trigger the discussion.
Very fine,
it
but
was
this
a
is
great discussion. So I gave you a 5 for it. Of course,
we agree otherwise. Can we go to your first study in the one which was actually significant? There were some. Can you move back? This one, yeah. In the upper panel, you see this. I'm not teaching. I'm asking. No. Mm-hmm. So, do you have any reasonable explanation that why the outcomes are so different in the 4 studies? That you put that in the rank, and then in one study there is no difference at all, and in the last one, the difference is very big. Mm-hmm. Is there any explanation for this? Because this is what we also try to understand, that why different studies are so different, because actually that shows. So do you have any clue on this?
Yes, for example, in case of Kelesh study, the 4th in the row, the intervention durated 8 weeks, and he integrated, so he studied children classified with gross motor function level between 1 and 4. In the opposite scene, he included only patients with gross motor function level 1 and 2. Gross motor function level 1 and 2, it means that the child is not dependent. He can move by himself. Mm-hmm. And we know that the mobility is linked with the respiratory health. So if the authors who included patients up to level 3, 4, they find the intervention more effective. And of course, the patients with classified at 1 and 2, they already reached their level of respiratory status, so the improvement was very small.